So, good morning, good evening, good afternoon, good late night, depending on where you are in the world. We're going to talk today about a few things, but before we get started, wanted to say thank you for Sax Girl Hornboy, our very first member on our YouTube membership channel. Membership helps us, it's like Patreon and some of the other things. It helps us, super chat buttons. All these things help us get life-saving information out all the way across the world. And if you're curious about it, a little bit less than half of our views are in the United States, a little bit over half are elsewhere in the world. In terms of patient care, we do see patients, we do consult with folks in South America, Central America, Europe, Middle East, Asia. China is our number 5 country for downloads for our audible and our audio information. So if you don't think much of the Chinese government and you don't think much of the politics, well, I don't think much of politics either. I try to stay out of it. And in fact, what I'm going to do is reiterate a couple of things. And why am I doing that? Well, we're coming off of a 2-year pandemic that just wreaked havoc with health, economy, and lives across the world. And many people thought this bug that created it was a bug that happened to attack you differently depending on how you voted. Obviously, I'm being a little bit sarcastic there, but despite the fact that I may try to stay out of politics, and you may think, well, this is medical stuff. How can that get political? Well, it does, and it did, and it will. One of the bigger reasons I'm bringing that up is that I think we're coming into a revolution in terms of the pharmaceutical care for diabetes and obesity, or diabetes and overweight, not obesity, and any level of overweight condition. And I will talk a lot about some of the new drugs that are coming out. For those of you who are familiar with the terms, the SGLT2s, and especially the GLP-1s, and we're going to talk a little bit today about a twin cretin. It's a slightly different kind of medication. Many people think it's just another version of the GLP-1s, like Ozempic. It's different. It's called tirzepatide. I've gotten a lot of questions and calls about tirzepatide. We'll have a brief 2-slide discussion about tirzepatide today, and we will then get into another biological medical issue, which again has been turned into a big political issue, and that is COVID-19 infection. So let me step back and make a couple of comments about my role and what I'm saying and what I mean when I'm saying it. So I'll tell you what I know about the evidence. One of the bigger issues that you see, one of the biggest problems, in fact, in social media is misinformation. It's interesting. I don't think that misinformation started with social media. I've got a very different impression on misinformation. When I was at Hopkins for a few years, early in my career, and at Hopkins, we used to talk about what we called denominator medicine. In other words, the rest of the medical community is talking about this one patient. We were talking about the whole population. And once you began looking at the whole population, things began to look very, very differently. And unfortunately, what you hear on the internet is some doctor giving an opinion based on one patient that they've seen, or one patient giving an opinion on what they have experienced as an individual. One of my I had 2 original goals in starting this channel. One was to start talking more about prevention, which is very unusual, and especially to talk about prevention from a trained preventive medicine specialist perspective. And the other thing was to give more of the facts as I see them, as you actually, as an epidemiologist. An epidemiologist is someone who looks at the quality of the information to say, okay, here's what we do know, here's what we don't know. And you'll see that in a couple of the studies that we talk about today, a little bit later, about long COVID resulting in increased risk for diabetes, increased risk for other diseases. There were a couple of studies there. One of them's a little bit better than the other in a couple of ways, but both of them are very, very informative for us as we begin to understand better our risk in the post-COVID world. So again, I'll tell you what I know about the evidence. I'll include as much detail as possible. And yeah, I've warned people out with detail. You know, they say, hey, doc, you're getting way too deep into the weeds. Just give me the facts. Just tell me what to do. And if you want to be just told what to do, this is not a good channel for you. That's not the way I tend to approach it. I give you the facts in as much detail as I can so you can make your own choices. I'll tell you what I do. You know, quite often patients will go through that long litany with me and then they say, got it, doc, understand. If you had this, if you were in my situation, what would you do? And I'll be happy to tell that as well. What I won't do, I won't tell you what to do, and I won't make choices for you. So, as I mentioned, today we're going to be talking about a couple of things. Again, another touch on that topic of the new medication classes coming out for diabetes and overweight, weight loss. That will be a short content, and then we'll go into the long content, and it's about long COVID, and it is more than just a flu. And, you know, we may have some haters on here that want to say, no, it's just the flu. And we may have some folks try to dogpile us. They've done it many times when we talked about vaccine. If we do, hopefully we'll deal with it. So previous topics have been, you know, it's one thing to hear from a dry old doc, and especially epidemiologist type who's just talking about details. It's very different to hear from a patient. And Lois is very, very good at sharing her information. She got into a position where she really didn't want to have procedures, but she agreed, and she tells her story about how it happened and why she agreed, and her post event analysis. Very, very interesting, and from a human looking at this from the inside out kind of perspective. Very different perspective, again, from me scientifically and dryly analyzing and dissecting it. We've, as I've said, we'll continue to cover a lot of information on the new anti-diabetic drugs and the weight loss drugs. We talked recently about intermittent fasting on aging and cardiovascular disease. If you're new to this channel, if you haven't been here, basically what we're about is helping people understand, first of all, become aware of the things that are really killing and disabling more of us than anything else. And the reality is, it's a lot simpler than we think. And unfortunately, it's not exactly what your doctor thinks, probably. And this is not just an internet doc. It's not just me saying that. I'm quoting scientific evidence. First started coming out from my old colleagues at Hopkins, but Mayo and Harvard have all started getting into the facts that 2/3 of primary care docs here in the U.S. don't know how to diagnose prediabetes, let alone manage it. So we've got a problem in terms of our medical establishment getting up to speed and catching up with prediabetes. A little bit too much focus on LDL and not enough focus on diabetes. So you're in that old adage, buyer beware, in terms of healthcare. Now, one of the things that we're doing is, again, trying to provide information for you so you know what to ask your doctor, you know the conversations to have. And within just a few hours, you can learn a lot more than most doctors know about about prediabetes, diabetes, cardiovascular plaque, cardiovascular inflammation, the things that really drive heart attacks, strokes. You know, these are the number one cause of heart attacks, number one cause of strokes, number one cause of blindness, and number one cause of dialysis, kidney disease. So it's not like these are unimportant issues. I would suggest you take a look. Most of these courses now, by the way, are about, well, between 1 and 3 hours, depending on how quickly you go through it. And most of them you can access for free. If you have any questions about how to access it, we're not trying to make money on these. We're just trying to get that information out there. I'm not going to talk about the subscription plans or the book today. I'm going to go straight into the short form content. Tirzepatide. Tirzepatide was covered in a New England Journal article recently. You see this over in the bottom right-hand corner, that NEJM stands for New England Journal of Medicine. It's the number one journal in the world for medicine, and in terms of hot breaking new news. And the hot breaking new news here is yet another medication, which is, you know, it's similar to the GLP-1s, but it's different. It's also called a GIP and GLP-1, an incretin, glucagon incretin proton protease agonist, and a glucagon-like protein 1 agonist. You see, I'm even stumbling over the names. Don't worry about the names, but just be aware that it's a new drug. I'm blanking on the name of it. Maybe somebody can remind me. It became available just a few months ago. These drugs are sort of like statins, and especially like metformin, in that we know a couple of the mechanisms, but we don't really understand all of them. If you look at the GLP-1 Ozempic, there's actually a significant amount of research going on about information on reward center activities in the nucleus. And why does that matter? Addiction. There's actually been significant amounts of research being done with addiction with GLP-1s for alcohol addiction, coke addiction, narcotic addiction, in addition to the addiction that we tend to talk about here in terms of food and carb addictions. So again, a lot of information coming out. Now, tirzepatide is, like I said, a little bit like the GLP-1. It's got some GLP-1 activities similar to Ozempic, but it has some other impact, some other mechanism as well. And when you put those two together, they had a big increase on the impact. So I've had a lot of folks call me recently or send emails and saying, "Hey, doc, what do you know about that new medication, tirzepatide?" And again, when I get over my senior word finding moment, I'll remember the Mounjaro, I think, Mounjaro, the brand name. I've had a lot of people calling about that, and there's a lot of potential advantage to this. Do I recommend going out and trying it? You know, I am not in a big hurry to try tirzepatide with patients at this point. I do think, and I feel very strongly, that not nearly enough patients are on the currently available GLP-1s, saxaglutinin, liraglutide, Ozempic, some of the others. I also feel very strongly that there are not nearly enough patients that are on the SGLT2s, and many of you have heard those names, Jardiance, Farxiga. Both of those drug classes have been out long enough. They've gone through all of the pre-market testing, the safety testing, and there are millions of people that have used these drugs with good experience. So I think there's clearly a good safety record for those drugs. Why aren't a lot more people on them? Because they cost so much. The SGLT2s like Farxiga and uh, some of the others in the area of $700 per month. And the GLP ones are even more, closer to $1,000 per month. So we're in that phase where Big Pharma has demonstrated very, very positive risk benefits for these medications, but now they're making their fortunes off of it. As I've covered in a couple of other videos, there does appear to be some loss of patent for one of the GLP-1s over the next year. I expect within 2 to 3 years, you'll see these drugs become much, much more widespread. Now, another comment about the SURPASS trials that were just published a few months ago in the New England Journal. They were done out of the US, UK, and Argentina. We continue to make progress on these with diabetes. Their endpoints are the same endpoints that people are accomplishing every day with lifestyle. Weight loss and decreasing your A1C in the absence of hypoglycemia. That's one of the other big advantages to these drugs. The older drugs for diabetes tended to have risk for hypoglycemia, weight gain. Insulin is the worst. It has significant risk for both hypoglycemia, which can be fatal, and it has a lot of weight gain, which becomes fatal it's more of a long-term death. Again, the newer medications are doing much better. Now, you cannot out-prescribe, you still can't out-prescribe a lifestyle. You can't out-stent a lifestyle. You can't out-bypass a lifestyle. Lifestyle's cheaper, it's safer, but it takes discipline. And discipline is often not easy. For those of us that have gone low carb, we do realize that going low carb makes it easier. It stops that glycemic roller coaster that you get with your carb-driven diets. So if you will give us the water ball, Gilbert, we'll go into long COVID, more than just a flu. So, as more people are exposed to and infected by SARS-CoV-2, reports of patients who experience persistent symptoms or organ dysfunction after acute infection develop post-COVID conditions. And that we've seen a lot of increase with it. I've personally seen it with my own patient group. We're going to talk about a couple of studies this morning, which are showing some significant increase in risk post-COVID. So the first one is a CDC report in the MMWR, Morbidity Mortality Weekly Report. Post-COVID conditions among adult COVID-19 survivors, age 18 to 64 and greater than 65. This is in March 2020 and November 2021. This was a big study, 353, 164 adults. They either received a COVID-19 diagnosis or a positive COVID test. This was in the Cerner EHR, electronic health record. So Cerner is an off-the-shelf electronic medical record. One of the big advantages of medical records over the old paper medical record days is that you can do studies like this, and you can get some very, very good information out of them. So what they looked at was the incidence of 26 different clinical conditions, 30 days to a year after the infection. 1 in 5 adults aged 18 and older have a condition that might be related to their previous COVID-19 illness. Let me repeat that and take a look at that image just to make sure that you got it. 1 in 5 of us, 20% of us, very well may have some issues. neurological, mental health issues, kidney issues, musculoskeletal conditions, blood clots, vascular issues, respiratory conditions, cardiovascular conditions. I say that as you hear me sniffle and snort. I had my own issues, and I do think that I've got a little bit of post-COVID from that. I'm very lucky, though, that I'll certainly survive having a 6-month cold. COVID-19 survivors have twice the risk for developing pulmonary embolism. That is often a cause of death. I mean, that pulmonary embolism is incredibly serious. The most common incident conditions were respiratory symptoms and musculoskeletal pain. Cardiac dysrhythmias, like atrial fib, they were higher among patients 18 to 64, as well as musculoskeletal pain we mentioned before. Those older than 65 had higher risk for renal failure, stroke, type 2 diabetes, muscle disorder, neurological and mental health condition. And I've seen this. I had a patient that I'm thinking about right now. I won't mention any demographics to not identify the patient, but this patient had glucose peaks up around 160, 180 during a glucose challenge, and had been stable on that for years. And insulin peaks around 50 to 70, not bad. Then post-COVID went up to glucose levels of 220 and insulin levels of 250. So they clearly had enough. Clearly their insulin resistance just went out the roof. Clearly they were making enough insulin to hit these higher levels, but obviously their pancreas is not going to do that for years. They will get to where they're not able to make insulin unless they slowed down. And this was a very good patient. They are very slow in terms of carb intake, so she will maintain a healthy pancreas. So discussion points on this. This was a very, very large study, over 300,000 cases, over 1 million controls. They pulled it out of electronic medical records, so that's got its pluses and its minuses. There were not much details about what type of respiratory problems they had. This was, the study was not being done in a controlled environment where they had, okay, these are the symptoms we're looking for. You just pulled what you could out of it. And there was not much detail about initiation or increase of diabetes. Again, there is a lot more to discover in terms of increased risk from diabetes associated with post-COVID. Now, here's the second study that I mentioned. This one was published in The Lancet. The Lancet has a reputation. It's, again, one of the better journals in the world for medicine. It tends to pull the trigger a little bit quicker, so they've had to retract a few more things than you would see retractions in New England Journal or a couple of the other journals out there, like Nature Medicine. But it's a really, really good journal. This study was titled Risks and Burdens of Incident Diabetes and Long COVID, a cohort study. So this is getting a little bit more towards my specific area. Okay, how much, we know that we're getting a lot of post-COVID related conditions, most commonly respiratory, musculoskeletal. I'm seeing a lot of them. I don't work in those areas. I work in diabetes and prediabetes, and I'm seeing it with diabetes and prediabetes, and that's what this study is looking at. The authors looked at the medical records of more than 180,000 people who had survived for longer than a month after catching COVID-19. They compared results with 4 million people without COVID infection who had used the VA healthcare system. People who had COVID-19 were 40% more likely to develop full-blown diabetes up to a year later. Hospitalization or ICU admission tripled that risk to more than double. Subjects were mostly older, white men with hypertension and overweight. Now, how much of that is because it was in the VA system? that's one of those areas where, as an epidemiologist, you begin to start asking questions. And they had some information about that. I think we've known from the beginning, you tended to see more problems in older people. You tended to see early on more problems with older white males. So there's still that signal there. How significant and important is it? Probably not very at this point. So discussion points. This didn't cover cases that were not tested or diagnosed. Now, that could actually end up cutting both ways. That could mean that, and I think it probably means this, that there's probably more risk associated with this than we're seeing, because what we're not recognizing is that a lot of people had cases that really didn't make it through the cut point to get labeled as a case. There's another way of looking at it. Undiagnosed COVID cases were included in the controls. And so that means diagnosed cases had increased risk, not undiagnosed cases. So again, you could cut both ways. What about preventive measures, masks, vaccines? Well, it still depends on what you believe about those. And again, masks and vaccines appear to help and have a good risk-benefit equation depending on your political leanings. Again, pardon the sarcasm. If you believe the vaccines decrease the probability of having a diagnosed case, then this adds to the risk side of not getting the jab. As I've made very clear from day one, I am pro-vaccine for this. I have no argument with folks that say, yes, there's risk with these vaccines. There's risk with every vaccine that we've used. The real issue is, again, benefits versus risk and weighing those. And I'm clearly on the side of, I've had my first jab, second jab, third jab, and fourth. More discussion. Lots of arguments about the vaccines. Most arguments about the vaccines were related to safety. My position from day one, no vaccines are 100% safe, just like trips in cars and airplanes. If you want to, well, I won't go there. This study doesn't speak to that. Other arguments against vaccines were that there was limited benefit. COVID is simply another cold or a respiratory infection, upper respiratory infection. I'm not hearing as many people say that, but I'm still hearing people say, well, it's not that big of a deal. Well, this study adds to the side of the equation that COVID is not just another cold. So as I said, what do? I tell you what I know about the evidence. I include detail as much as possible. Let you make your choice. I'm not going to tell you what to do. I will tell you what I do if you have an interest. And I'm not going to try to make choices for you. So having covered that, let's get to the Q&A. Gilbert, will you give us the transition? Thank you, Gilbert. So we got Sax Girl Horn Boy became a YouTube member. Thank you so much, Sax Girl Horn Boy, helping us get that information out across the world. Bambi Grage, good to hear from you again. Bambi, can you raise ejection fraction? A friend's is 35. Yes, you can. There are medications that have done it. People have done it with lifestyle. And in fact, you bring up a really good point. Low ejection fraction, for those of you that don't know, if you consider this bad visual as speaking of visuals, I have to point out, that's our logo right there. I'm in Alabama, as you may have figured out. And there's a very old lighthouse here in Mobile Bay that's famous, and that's a picture of it. And that Jubilee is a unique Mobile Bay thing that I'm not going to get into. But now let me go back to the digression that I was in a minute ago, talking about Bambi's question. If you consider this the left ventricle of the heart, so it expands and fills up with blood, and then it squeezes. It doesn't. You don't get 100% ejection. So the ejection fraction is the amount that that you have here when you've contracted and quote emptied it, because you don't completely empty it, divided by the amount when full. So when you have heart failure, and normal ejection fractions are 60%, and when 50%, when you see people that have ejection fractions around 30%, 35, those are low. So there are several things that can cause that. Most of them are related back to prediabetes and diabetes. One of them is what we call a myocardial infarction. In other words, a part of the heart muscle, let's say this part of the muscle just gets paralyzed and it can't contract. So that then you get a decrease in the ejection fraction. If you get significant decreases in ejection fraction, you have what we call heart failure. Guess what the most important thing to do is if you have heart failure? Exercise. So again, it all gets back to the very same thing, and the very same components of exercise. Managing your weight, by far the most important thing, but then exercise. And both of those are the most critical things for people that are in heart failure. And yes, they can improve their heart failure dramatically with those things. Are there drugs? Of course there are drugs, and there are a host of drugs which have impacts on ejection fraction. Great question. Thank you so much, Bambi. John Tocho, good morning. Slim Chickens. I don't think I've seen you yet, Slim. Good to have you here. Thank you. Margaret D., good morning from Winnipeg. Bobby Ocampo from the Philippines. Mabuhay. God bless you for saving lives. Thank you, Bobby, for your participation. John Tocho became a YouTube member. John, thank you so much. Again, this is helping us get this information out across the world. Doesn't matter what your politics are. For me, I still think all of us deserve to get access to life-saving information so we can take care of our health. So John says, I just went premium. Don't know how I missed this before. Thank you so much, John. Really appreciate it. So I think that's, as usual, Gilbert's on the ball. If you'll look up in the upper right-hand corner, he's showing you how to do that. You go right here and you can hit join. Sandra Dabrowski, greetings from Huntsville, Alabama. Greetings to you, Sandra. Thank you for joining. And Sandra's on Facebook. Most of our folks are coming in from YouTube, but we do have some Facebookers as well. My Loisa Eslao Cabardo. Yo hablo un poquitísimo español. Es probablemente evidente. I speak a little bit of Spanish, and that's very little, very, very little, and that's probably obvious. But Eslao Cabardo is not from, Cabardo is from the Philippines. We do have a significant following in the Philippines. Thank you for sharing that. And a lot of that comes from our team. Our team is most of our production team, channel production team, like Gilbert, is located in the Philippines. Cebu, Manila. Gilbert, if you can remember the area that Aspen's from, and you feel comfortable letting us know, please do.
Davao.
Davao, and he's near a place where there were significant, there was some significant violence. It was associated with some religious.
Yeah, Marawi.
Yeah. So it actually made the global news for a while. ET himself, about long-term side effects from Pfizer Vax. My first one went well, although the other two, 6 months apart, chronic fatigue, always sleepy, brain fog, etc. Thanks for sharing, ET. Sorry to hear that. Hot Wheels 66, I had first 2 jabs, but never got the booster. The first 2, I was sick, so do not want that again. You know, even they talk about decreased function or decreased protection if you don't get the 3rd and 4th. Here's the thing. The infection rates, I don't know if anybody's been how many people have been keeping up with it, but the infection rates have been as high as ever. Some of their peak rates just recently in a lot of places in the US, but the hospitalization rates have been very, very low. So the bottom line is there's a lot of protection going on. Bobby Ocampo, what's your comment on chromium for insulin sensitivity? There is some significant evidence that chromium is helpful. I do think it's worth taking. It's like the lower or bottom tier of supplements to consider taking, with vitamin D3 being at the top, niacin being at the top, especially if you have, for people with Lp(a) and some of the other lipid associated issues. Good question. I think magnesium is more important, for example, than chromium for a host of reasons. ET himself, not too fussy about the fourth. Slim Chickens, I'm currently on Ozempic. Thank you for sharing that. I want to try Wegovy, but my insurance doesn't cover it. It's $1,400 a month. You know, that's interesting. What we're starting to see is some programs where you're getting increased access. I noticed Medicare, for example, has some programs where you can get access to Farxiga. That's on the SGLT2 side. It also has some access to Ozempic. Ball, prevention is not profitable. That's correct. You know, it's like lifestyle. There's zero cost for that, and zero charge for that. And, you know, I realized that when I first went into medicine, didn't know what I wanted to do. Enjoyed surgery quite a bit. And prevention just seemed awful. It seemed like, you know, there were worse things. There were few worse things that I grew up in my life, worse than being a teacher or an accountant. I hated numbers and I hated, you know, the Charlie Brown. And when you go into preventive medicine, you end up looking at denominators. You look at numbers and you do teaching. So it's like, be careful what you say you'll never do. I ended up starting in the ER in my career, and there were so many experiences where I was running a code, $15,000 to $30,000 worth of, you know, just being expended on people who were already practically dead by the time they got into the ER, with heart attacks, strokes, things that they woulda, coulda, shoulda never had. And here we're just, you know, sticking needles in them, intubating them, knowing that we're not going to get them back. That was a frustrating process. And after enough of those in the ER, I came to a moment of truth and said, you know what? If this, you know, if my career's about me, then yeah, I'll continue to go on into some kind of surgical specialty. But if my career is really about helping people, I'm going to become an accountant and teacher and do preventive medicine. So I made my choice. Hot Wheel 66, I lost 50 pounds on a low carb, was pre-diabetic. Losing 50, I've got a lot of people that lose their prediabetes altogether with significant weight loss like that, Hot Wheels. Thank you so much for sharing that. Was pre-diabetic with hypertension, now all normal without medications. Thank you so much for sharing that. Bobby Ocampo, if fasting helps, why not have a long hospitalized fasting, say 20 days, supervised by medical practitioners in hospital or healthcare facilities? It's a really good question. It seems obvious, but the bottom line is find an insurance company that's going to pay for that. Most of them are going to say, no, you know what? Do a 5-day fast. It's safe. Refeed for 2 or 3 days and do another 5-day fast. It's safe. Or one of the more practical, relatively easy. You know, none of the fasting is easy. Yeah, food addiction is a big deal, but these people that started at 300 pounds, you know, have, you know, major weight to lose. You see this in Jason Fung's book, for example, talking about a lot of people who do this every other day, fasting, and just do it for month after month after month after month. And that's the point, Bobby, because that kind of fasting is so safe, you're never going to get people to pay the thousands of dollars that it costs in the US to put somebody in the hospital. It's just that safe. It's just not easy. If we did that, though, it would save so many dollars in terms of heart attacks. It would save lives. Again, prevention's not that well recognized or funded. EGA 0117, is taking the vaccine dangerous? Gosh, it really depends on who you talk to. I obviously don't think it is. I'm one of those that took it. Passing through. Hi, good to hear from you. EGA 117. Is the COVID vaccine okay? I think EGA, we may not, unless you get something a little bit more better quality than that on the questions, we may not be entertaining those. Fort Worth West Side. Do all statins push one towards insulin resistance? Not all of them. And if so, how and at what dosage does this happen? It's a really good question, Fort Worth. So up until the development of pitavastatin, which goes by a couple of names, Pavesta is the most common generic name, and Livalo is the most common brand name. Pitavastatin does not push you towards insulin resistance. And they have not lost their patent yet. So they're, most insurance, they're very expensive because of that. And most insurance companies will give you a hard time paying for it because it's expensive. So, but even before that, there's a very simple, easy to take statin, and in these lower doses does not significantly increase. I use a lot of oh gosh, I'm having a senior moment. Rosuvastatin. The brand name was Crestor. Use a ton of that, 5 milligrams a day or less. Now, most docs end up using a much higher dose, and most docs are looking at LDL levels. When you actually look at statins, they're sort of like these other drugs that we've been talking about that have multiple different effects. One of the effects of statins is to decrease cardiovascular inflammation. In other words, your immune system attacking the plaque in your artery wall. Well, that's one of the reasons I don't give the most popular statin because it doesn't work as well for cardiovascular inflammation for diabetics. And again, 70% of us with heart problems either have prediabetes or diabetes, and it's likely to be higher than 70%. So rosuvastatin, 5 milligrams or less. And with rosuvastatin, you can take, I actually have some people on 2.5 milligrams once a week. I don't really recommend that, but anywhere between those and 5 milligrams a day are very, very commonly used doses by me, at least. And those doses do not have a significant increase in terms of insulin resistance. I hope that helped, Fort Worth. It was a great question. Thank you so much for bringing it up. John Tocho, if you had the vax, how would you know if you had COVID-19 either before? That's a good question. Really good question. And most of the time, what they're talking about is proven by the nasal swab test, not proven by the antibody. Great question. So what John's saying is, if you get the vaccine, you're going to get a positive antibody test. So if they draw blood, you get the vaccine, they draw blood a little bit later and say, well, the antibody's positive. That's from the vaccine. How do you know whether it was an infection or not? Imbald, but these medical records will be missing things such as vitamin D levels. Exactly, Imbald. Thank you so much for bringing it up. And as I said, these are What do you always see at the end of any academic research article? More research is needed on blank. And that's what happens. It's just an ongoing cycle. And that's one of the problems with these studies. They're great in terms of numbers. And I think they do show a lot of power, a lot of reliability in terms of that perspective. But there are a host of questions that they don't touch on at all. What were the symptoms? What were the other conditions? For example, in this case, what were the vitamin D levels? We know that's a very important item. Michael Sanders, hello from Arizona. Good news. Monsoon season has begun. Well, I guess that's going to cool things down in Arizona a little bit, and I bet you needed it. Love the rain. Thank you so much, Michael, for joining us and commenting. Fort Worth West Side. Wonder if they ever did a study to determine how many who died from COVID were actually insulin resistant and very low vitamin D levels. They did enough studies to know that both of these were incredibly important. But the one about actually had insulin resistance reminds me of the whole thing about dementia and insulin resistance. They know that insulin resistance is a major risk factor for dementia, but they don't know how big a risk factor it is, because how many people, I have never seen a study which actually looks at full-blown insulin surveys, let alone even a oral glucose tolerance test. They just, when they look at this risk factor, they're just looking at A1C. Well, as we know, we've discussed it many times on this channel. If you're not eating carb, there are a whole bunch of reasons you can have a very low A1C, but still be full-blown diabetic. In fact, the vast majority of my full-blown diabetic patients have low A1Cs. Why is that? Because they're not eating carbs. The American Association of Clinical Endocrinologists has said, don't make a diagnosis of diabetes based on A1C for a whole host of other reasons. They didn't even mention that one, which is the most common in my practice. Anything that causes liver or kidney disease can change hemoglobin. Remember, it's not just the A1C part, it's the hemoglobin part. Glucose, when it's elevated in the blood, will bind to proteins. That's how it causes its damage, by the way. Hemoglobin is a protein. It's a protein. Hemoglobin carries heme, which in turn carries iron, which in turn carries oxygen. But we can actually estimate how high the glucose is over a 3-month period by looking at how much glucose is bound to the protein in hemoglobin. So you go back, you look at that, that's what they're using for most of these studies. So they don't really know how strong the risk of insulin resistance is for any of these diseases, COVID death being one of them. In fact, when you think about it, if you acknowledge, and I'm not the only one saying this, 90% of people that have diabetes don't know it, and 90% clearly, and it may be as low as 2/3, maybe as low as half. With insulin resistance, it's clearly the 90%. It's the higher amount that have insulin resistance don't know it. When you realize all of those people with insulin resistance that don't know it are contaminating the quote controlled side of these studies, then you begin to realize the risk is much, much higher. They've seen a significant risk, but it's actually much higher than the researchers judged. Andrew McDonald. Hi, doctor. Is testosterone levels something you look at in your patients? And if found to be low, do you recommend replacement? It's a great question, and it's a long story. I'll just go down a little bit of a bunny hole over it. So for a long time, many of us thought that testosterone might actually be a risk factor for heart attack and cardiovascular disease. That was based on the assumption that, men get cardiovascular disease earlier than women. So therefore, when the testosterone replacement fad started happening, many of us were very concerned about potential increase in cardiovascular disease. That did not happen. In fact, there were a significant number of studies. There were 4 key studies, and these happened between 5 and 10 years ago, looking at the risk for testosterone. It wasn't there. It did not increase risk for cardiovascular disease. Now, the other thing that they found was it really didn't impact all of the things that people were hoping. What it did do was increase people's sleep quality. So how much it actually helps is an argument point. I'm not going to get into that debate. What I will say is, on a practical basis, what do I do about it? And I don't get involved in it. It's a totally separate reason. Testosterone is still classified as a controlled drug in most states. I've been trying to get people access to better health care through telemedicine for 20 years. And now that it's becoming a, be careful what you ask for, the pandemic has created a whole new receptivity to telemedicine. And after my 3rd or 4th retirement, I'm again busier than I've ever been, but happy doing a lot of work for this. I'm not going to jeopardize my ability to provide the medicine that I'm providing by also prescribing controlled drugs, because when you do controlled drugs by telemedicine, it becomes a very significant increase in risk. Now, again, Andrew, I'm not saying I don't use it. I'm not saying that they're inappropriate to use. I'm not saying you can't get these by telemedicine anymore. There are a couple of companies that specialize in this and are doing a good job. Do I recommend replacement? Again, it's I think the clinical data is just not that clear to support it yet. We got a super chat, $20, tired looking for name. Thank you so much. It says thanks to Dr. Brewer and the PrevMed team. Thank you so much for that super chat, tired. Again, that helps us get this information out to the world. Is COVID vaccines? Okay, we got one of those. MBall, will they bother to check the records for early COVID treatment? No, I don't think they're going to get much deeper on looking again at those records. I think what needs to happen is, further research. Life extension research. Tell also the new findings related to the vaccine is one of the possible causes of long COVID. Not going to go there yet. Haven't seen a whole lot of stuff in that area, evidence yet, high quality evidence. MBall. Glucose can go crazy with many infections and not just COVID. Absolutely. That is a big deal. Any check on microbiome? No. As you might guess, this microbiome is clearly not one of the issues that they're going to cover in that space. Okay, we're getting tons of comments now. And I've got 7 minutes before my next meeting. I apologize, but I am not going to. I'll get to a few more. One of them is a friend, Aura Ruth. How are you, Aura Ruth? Hi, Doc. My hubby got careless and sick with COVID. I got sick June 9th. I'm still antigen positive. O2 sat never went below 92, but I'm very weak. Thank you for sharing that. And I'm sorry to hear you're having a problem. MBall, the vaccine is like a seatbelt in the plane and forgetting to fuel the plane. Good point. It's make sure the plane is fueled. Bobby Ocampo, in the Philippines, our all-cause mortality rate is lower with COVID. We have less death in 2020 than 2019. That is interesting. Death to pneumonia was down 50% from average. That is interesting. So, as an epidemiologist or anybody, you start thinking about, well, there was significant decrease in interpersonal interaction. So there were, flu bottomed out. You just did not see that much flu during those 2 years. Maybe there's an issue that flu and other infectious diseases were that big of a deal. You also begin to wonder about the age distribution. Of all the continents, the African continent was the least impacted by COVID. Why was that? Because of their age, their demographics. They are by far the youngest population in the world. Now, why are they the youngest population? Because so many of the older generations have died off from AIDS, HIV. So there's always another story, isn't there? Exercise. Andrew McLeod. Again, we're going to blitz through a few more and then have to leave within a minute or two. Andrew McDonald. Can statins lower ejection fraction and or cause dilated cardiomyopathy? That is not a common, that would be a very unusual reaction, Andrew. James Lester. Just had a calcium score of 1250. I'm asymptomatic. I'll see my doctor this morning. Should I ask for a low dose of Crestor? I've been keto for 4 years and am now metabolically healthy. This is a great one to end up on. So I've had so many people come to see me. In fact, the most common reason for coming to see me is a positive calcium score. Then people will get religion. They will change their life. They'll lose 30 pounds. We'll get sometimes medications. We'll get things done with them. And then they'll go back and they'll say, hey, I'm going to go do another calcium score because I expect to do a victory lap because it's going to reverse. Rare. I've had a couple of people that it reversed on, but that's rare. That's not the biology. It's not appropriate to expect that. In fact, if you understand the biology, James Lester, if you've done some things to improve, you're more likely to increase your calcification. But that's not always a bad thing because it's the plaque that doesn't show up on a calcium score that's dangerous. Once it's calcified plaque is stable. And I've covered plenty of studies on that. The Honda study's the one that was most visually out there. You could see the calcium. You could see the decreased event rate in that population. So don't assume that getting that calcium increased is a bad thing. Regarding the selection of statins and when I use statins, I definitely do recommend that you consider a statin. I've got a lot of patients that have very, very high LDL levels. When you do what I do, you get a lot of folks with what's called familial hypercholesterolemia. I get a lot of those. But I don't routinely use a lot of statins just for LDL levels alone. I do recommend anyone with a positive calcium score to consider a statin. And like I said earlier, I usually don't come out of the blocks with a high dose. I usually come out with the either Crestor 5 or lower, or Zipatamag, one of the biologic generics of Livalo. I have to run to my next meeting. I've got a lot more comments. I appreciate the interest, and hopefully we can get to some of those next week. Thank you so much.